Welcome to the Indian Council of Medical Research Online Prescribing Skills Course 2020 for the Indian Medical Graduate. I am Dr. Jayanti and I am going to talk on prescribing for heart failure. After this video, please answer the 5 multiple choice questions which you can access on the assignment section. Now let us start the module Prescribing for Heart Failure. I would like to thank all the authors who have contributed to this module. At the end of the module, the learner shall be able to state the principles of management of heart failure in order to prescribe rationally for such a patient, to identify the risk factors which can lead to or precipitate heart failure and prescribe rationally before referring a patient for risk factor modification. Also, to prescribe rationally for a patient with acute heart failure before transferring to a specialist care, the learner should be able to state the indications for referral to a specialist and also communicate to the patient about the medications and also provide instructions regarding lifestyle modifications in a simple language. The learner must be able to counsel a patient regarding adherence to the prescribed regimen and also to suggest measures to monitor the adverse effects of medicines. Now, why is this topic important? Heart failure is known to affect about 26 million people worldwide, and India alone the annual incidence is around 0.4 to 1.8 million. As you know, heart failure is a progressive disease and it is associated with a gradual reduction in the cardiac performance, acute exacerbations which may require hospitalization, and also it is associated with shorter life expectancy and a poor quality of life. Heart failure is known to impart a major burden on the healthcare system, and by 2030 it is projected that the number of heart failure patients will rise by 25%. For better understanding, to prescribe rationally, a case scenario has been provided. A 65-year-old obese postmenopausal woman, a known case of diabetes mellitus, well controlled on metformin for the past 10 years, comes for routine blood pressure examination. You check her BP and find that it is 146 by 94 millimeters of mercury. Now, how do you approach this case? Risk factors for development of heart failure like hypertension, ischemic heart disease, diabetes, obesity, they need to be identified and controlled in order to prevent development of heart failure or further progression of an underlying disease. Additional history to suggest a structural heart disease needs to be elicited. You need to ask for history of dyspnea on exertion, orthopnea and paroxysmal nocturnal dyspnea. Ask for history of recent weight gain which may indicate fluid retention if there is an underlying heart failure. Ask for past history of hypertension, ischemic heart disease, myocardial infarction, investigation suggestive of altered lipid levels, history of smoking or alcoholism especially if the patient is a male, history of stroke or uncontrolled diabetes mellitus or a history of rheumatic heart disease. Also ask for adherence to the medications if any of the above mentioned conditions exist. Now, in clinical examination, what do you need to look for? Because the case scenario provided, there was a mild rise in blood pressure, you need to repeat the blood pressure recordings to confirm hypertension. That is, if you find the blood pressure is more than 140 by 90 millimeters mercury, then you can diagnose hypertension. You also need to look for features of structural heart disease such as an increased heart rate, increased respiratory rate or added heart sounds, raised JVP, signs of fluid retention or organomegaly. You also need to look for factors which can aggravate heart failure such as signs of anemia, any indications of atrial fibrillation or a valvular heart disease. since these may require further investigations and cardiologist referral. Now, identifying the symptoms and signs will help to diagnose a patient with heart failure. The symptoms for heart failure like dyspnea, orthopnea, PND, a pink frothy sputum, dependent pedal edema, history of recent weight gain, easy fatigability, history of congestive heart failure or myocardial infarction in the past, and signs such as tachypnea, tachycardia, irregular pulse, basal crepitations, cardiomegaly, presence of murmurs or systemic desaturation. They are all indicative of an underlying heart failure. To understand the management of the case scenario provided, we need to consider the classification of heart failure based on risk factors, symptoms and signs. Heart failure has been classified based on American College of Cardiology or American Heart Association guidelines into 4 stages. Stage A, no symptoms or signs of heart failure, but risk factors are present. Stage B, no symptoms of heart failure, but there is evidence of structural heart disease. Stage C, symptoms with marked or mild exercise. And stage D, severe symptoms exist even at rest. Now, what is the diagnosis in this case? This is a case of postmenopausal obese women with diabetes and hypertension with stage A or B heart failure depending upon the symptoms or signs suggestive of structural heart disease. Now, do you think this woman needs to be started on any drugs other than metformin? She has multiple risk factors like diabetes, hypertension and obesity. If not adequately controlled, can cause structural and or functional changes in the heart, reduce the cardiac output, which initiates feedback mechanisms that are counter-regulatory and increase workload on the heart. This can gradually progress to heart failure either with preserved or reduced ejection fraction. So, she needs to be started on antihypertensives. Among the various classes of antihypertensives available, angiotensin converting enzyme inhibitors or angiotensin receptor blockers are preferred, as they can control blood pressure as well as prevent cardiac remodeling and heart failure. AC inhibitors or ARBs have multiple benefits. They reduce vascular resistance, decrease cardiac pre and afterload and lower BP. They inhibit the action of angiotensin II on blood vessels and heart to prevent remodeling, improve tissue perfusion and help to prolong life. They also delay the development of diabetic nephropathy. Now, which AC inhibitor or ARB to prescribe? Enalapril is an efficacious AC inhibitor. It is as efficacious as other AC inhibitors. It is time tested and cost effective. So, you may prescribe tablet enalapril 2.5 mg once daily for 1 month. If not tolerated by the patient due to persistent dry cough, ARBs may be replaced. So, you may prescribe tablet telmisartan 20 mg once daily for 1 month. Tablet metformin may be continued as before if blood sugar and HbA1c are under control. You need to remember some points while treating patients at risk for heart failure. Factors that can precipitate heart failure such as anemia, tachycardia, which could be atrial fibrillation, must be identified and treated or referred. You need to monitor blood pressure regularly and check potassium levels while prescribing AC inhibitors or ARBs. You need to ask for history of intake of potassium supplements, drugs such as spironolactone, which are known to potentiate the AC inhibitors or ARBs induced hyperkalemia, and you need to avoid them. Some more points to remember. Explain the importance of salt restriction, weight reduction and adherence to medication to patients with risk factors for heart failure. If anemia is detected, you need to treat it with tablet ferrous sulfate or any other iron salts. You must remember to continue iron therapy for 3 months after full correction of hemoglobin to replenish the iron stores. If you detect thyrotoxicosis, you must treat with propyl thiouracil or methimazole and beta blockers like metoprolol. You need to understand that all cases of at-risk patients cannot be treated by you and you need to refer them to a cardiologist. So, the indications for referral in case of heart failure would be stage B chronic heart failure based on the ACC or AHA classification. On follow-up visit, if the patient develops signs or symptoms suggestive of stage B heart failure, then you need to refer. If you suspect risk factors such as atrial fibrillation or valvular heart diseases, then again you need to refer. What you should not do while treating risk factors that predispose to heart failure. Do not prescribe diuretics in asymptomatic heart failure as it may worsen the disease in patients with left ventricular dysfunction and does not have any effect on progression of heart failure. Do not prescribe non-selective beta blockers like propranolol in patients with risk factors as they can worsen heart failure. Do not prescribe AC inhibitors or ARBs in pregnant women with heart failure as they are fetopathic and they can cause growth retardation. Now consider another case scenario. A 50-year-old gentleman, a known hypertensive on enalapril 5 mg once daily, presents with complaints of fever, cough with expectoration and breathing difficulty for the past 5 days, not relieved with paracetamol and home remedies for cough and cold. He gives history of difficulty in breathing with palpitations while doing strenuous activities which gets relieved with rest for the past 6 months. Now, how do you approach this case? In order to ascertain that this is a case of heart failure, ask for history of orthopnea or paroxysmal nocturnal dyspnea, ask for history of swelling of limbs or weight gain in order to indicate fluid retention. Now, respiratory, metabolic, renal and other causes of dyspnea needs to be ruled out. So, you need to ask for pattern of fever, night cough if any, color and consistency of the sputum and pain on inspiration if any. These will suggest upper or lower respiratory tract infection. You need to ask for any history of diabetes, ischemic heart disease in the past or any renal disease or any history of smoking or alcoholism. Now, what to look for in clinical examination? Look for pallor, bilateral pitting pedal edema and abdominal distension. Check the pulse rate, respiratory rate, check blood pressure and JVP. Auscultate for the heart sounds S1, S2 or for any added sounds such as S3 gallop. Auscultate the respiratory system for bilateral breath sounds and for any rales or rhonchi. Check if there is hepatomegaly and also look for hepatojugular reflex. What investigations must you order? Check hemogram and iron binding studies to detect anemia. Do a urine analysis to look for albuminuria. Check thyroid function tests to rule out either hypo or hyperthyroidism. Check the fasting blood sugar, lipid profile. Check blood urea nitrogen, serum creatinine, serum electrolytes. Order for a 12-lead ECG if facility is available. For patients on follow-up, monitor serum electrolytes and creatinine. From the history alone, heart failure can be classified depending upon the time of onset as acute heart failure when there is a sudden onset or there is worsening of signs and symptoms, or as chronic heart failure when the symptom signs are persistent for more than 3 months. If the echocardiography findings are available, heart failure can be classified broadly into heart failure with preserved ejection fraction. When the ejection fraction is more than 50%, heart failure with mid-range ejection fraction, that is between 40 to 49%, and heart failure with reduced ejection fraction if it is 40% or less. Again, from the history, based on the severity of symptoms, you may classify heart failure into 4 classes based on the New York Heart Association classification. Class 1, there is no limitation in physical activity. Class 2, there is slight limitation in physical activity, patient is comfortable at rest. Class 3, when there is marked limitation in physical activity and symptoms are present with routine activity. And class 4, when the symptoms are present even at rest. Now, considering the case, it is a case of class 2 heart failure, otherwise stage C, exacerbated by respiratory tract infection with underlying hypertension. Now, how do you treat this patient? Loop diuretics are the mainstay of treatment for acute heart failure as they have a high ceiling effect. Efficacy increases with increase in dose. Furosemide is a time-tested, cheap and commonly used loop diuretic for management of acute heart failure. Intravenous furosemide can provide rapid symptomatic relief in acute left ventricular failure by increasing the systemic venous capacitance. Now, what is the treatment will you prescribe for this patient? You may prescribe injection or tablet furosemide 20 mg BD to start with, depending upon the severity of the symptoms. This needs to be gradually increased based on the response. You also need to prescribe tablet enalapril 5 mg once daily and tablet metoprolol extended release formulation 25 mg once daily. For dose escalation, you may refer to the reference material provided. Now, AC inhibitors and beta blockers, they reduce the effect of counter-regulatory neurohumoral mechanisms which are stimulated in heart failure and which could lead to progression of the disease. Now, what advice will you give to the patient? You need to advise the patient about lifestyle modifications such as salt intake by avoiding adding extra salt to cooked food and to avoid strenuous exercise. Blood pressure needs to be monitored regularly in the beginning to check for hypotension, as all the drugs can reduce blood pressure. Regular monitoring for weight is a simple measure to indicate improvement with treatment. You need to review after 2 weeks with serum potassium levels or earlier if there is worsening of symptoms. Patient need to be told about dry cough that may occur with AC inhibitors like enalapril and to report if it is disturbing. Now, it is important to understand the indications for referral in heart failure. If at any time during treatment of the patient you find that the systolic blood pressure is less than 90 millimeters of mercury or above 200 millimeters of mercury, if the heart rate is less than 50 per minute or more than 120 per minute, or the respiratory rate is more than 30 per minute, or there is cyanosis, or if you find oliguria or altered sensorium in the patient, all these are indications that you have to refer the patient immediately to a higher center where other drugs such as digoxin or vasodilators and other measures can be taken. Now, for some additional information, in case of acute heart failure, you need to start oxygen therapy and give injection morphine IV to relieve the pulmonary congestion. You may consider vaccination for H influenza in elderly and immunocompromised patients. Tablet spironolactone 12.5 to 25 mg dose may be added to the above drugs if symptoms persist. You will need to monitor for hyperkalemia. Monitor blood pressure regularly as all the drugs can cause hypotension. Monitor input-output requirements. Sufficient hydration has to be ensured as well as avoid fluid overload on the kidneys. Check the renal functions to assess impaired kidney function. Monitor blood pH, electrolytes and blood sugar regularly in patients on long-term diuretic therapy. While prescribing AC inhibitors, ARBs or spironolactone, you have to monitor the potassium levels and watch for dry cough when prescribing AC inhibitors. Calcium channel blockers, thiazolidine diones and NSAIDs must be avoided in patients with heart failure because they can worsen the symptoms. Now, for some additional information, you need to treat the underlying cause of anemia if detected. For mild to moderate anemia, you can prescribe tablet ferrous sulfate 200 mg twice or thrice daily, and the iron therapy needs to be continued for 3 months after full correction of hemoglobin to replenish iron stores. In case of severe anemia, that is hemoglobin is less than 8 gram per deciliter, you may start blood transfusion or packed RBC transfusion after expert opinion. Loop diuretics need to be started during transfusion in order to avoid fluid overload. Now, what you should not do in case of heart failure management. Do not prescribe furosemide at bedtime in order to avoid frequent waking up by the patient at night time. Do not use thiazide diuretics in patients with GFR less than 30 to 40 ml per minute. Do not prescribe non-selective beta blockers like propranolol as they can worsen the underlying heart failure. Do not prescribe beta blockers in acute or decompensated heart failure. If you encounter a patient who is already on digoxin for heart failure, ACE inhibitors should not be used to replace digoxin because the heart failure can worsen. Do not use transdermal nitroglycerin patches in patients with heart failure because they do not have any continued action in these patients. Do not use thiazolidinediones and NSAIDs unless otherwise unavoidable. Do not use ACE inhibitors in pregnancy because they are contraindicated. Digoxin should not be used in patients with heart failure in normal heart rhythm. It is to be used only when the combination of drugs are not effective in controlling the symptoms. Adverse effects of digoxin include GI symptoms such as nausea, vomiting, abdominal pain, xanthopsia or yellow vision, and ECG changes. Now, some take-home messages. Risk factors to heart failure must be identified and rationally treated as prevention is the best option. The important risk factors for heart failure are hypertension, diabetes, obesity, coronary artery disease, ventricular tachycardia with atrial fibrillation. Infections and poor adherence to medications can precipitate an episode of acute heart failure. Chronic heart failure needs to be treated with ACE inhibitors or ARBs and beta blocker with or without loop diuretics. Spironolactone needs to be added when the above drugs are not effective. Regular monitoring of blood pressure and electrolytes is required when above drugs are prescribed. All cases of heart failure with symptoms need to be treated with diuretics, and when severe, oxygen and morphine needs to be added. All cases of heart failure with stage B and above need to be referred to specialist care for further evaluation and appropriate interventions. Drugs having a potential for exacerbating heart failure like NSAIDs, calcium channel blockers, thiazolidinediones in those with pre-existing heart disease must be avoided. Now, these are the references for further reading. I would like to acknowledge the RUMC members from JIPMA Pondicherry. Thank you for watching this video. Please access the MCQs in the assignment section and upload the answers. Please also complete the assignment 2 as per the tutorial, which I am sure you have already seen. Thank you and happy learning.